The topics of today's lecture are blood pressure and also hypertension, shock, and congestive heart failure. This is a quick reminder. We've gone over this equation before, but this is probably one of the most important ones to know, which is blood flow equals delta P over resistance. This formula indicates that the amount of blood flow, the volume per unit time, will be increased if there's a bigger difference in pressure between one region and another region. And the blood flow will be decreased if there's greater resistance to blood flow. So this is one form of this equation that's very useful. We can rearrange it by simply multiplying both sides by resistance, and then we have delta P equals blood flow multiplied by resistance. So this is also quite useful. So for example, we can, applying this to the cardiovascular system, arterial blood pressure, which is delta P. This could be, for example, mean arterial pressure is equal to blood flow, which is cardiac output, multiplied by resistance. So the resistance through the systemic circuit is the total peripheral resistance. And of course, the cardiac output is the volume of blood moving out of the heart per unit time. So for example, in typical adults, about 5 liters per minute. And the parameters that impact cardiac output are in fact cardiac rate and stroke volume. In fact, if you want to calculate cardiac output, you simply multiply these two together. And total peripheral resistance depends on vasoconstriction and vasodilation. So for example, if you have vasoconstriction of many of the arterioles in the body, that would increase the total peripheral resistance. If you have vasodilation, that would decrease the total peripheral resistance. So using this formula, what is the effect of an increase in stroke volume on mean arterial pressure? What is the effect of an increase in total peripheral resistance on mean arterial pressure? And what is the effect of an increase in blood volume on mean arterial pressure? The answer is that all three of these changes would result in an increase in blood pressure. Let's look at these in turn. So if we had an increase in stroke volume, that would lead to imagine everything else is the same, like cardiac rate stays constant. That would lead to an increase in cardiac output. We're imagining the total peripheral resistance is held constant, and therefore you'd have an increase in mean arterial pressure. What about an increase in total peripheral resistance? Well, again, we imagine that cardiac output might be constant, and if total peripheral resistance increased, then the mean arterial pressure would increase. What about an increase in blood volume? Well, blood volume isn't explicitly shown in this equation, but we can sort of use our knowledge to understand what would happen. So when you have an increase in blood volume, there's increased venous return. An increased venous return would mean there's an increased end diastolic volume. And according to the Frank-Starling law of the heart, an increased stretch of the atria and the ventricles would lead to increased contractility. And so the stroke volume would therefore be increased due to the increase in end diastolic volume. So there you go. So that would increase cardiac output, and that would lead to an increased mean arterial pressure. According to the equation we just looked at, an increase in total peripheral resistance leads to an increase in mean arterial pressure. In order to picture that, there's actually a very good diagram. This is from your book. And this shows pressure. So the higher a column of blood, the more pressure there is. So this indicates the pressure that's generated by the heart. So that's, of course, the source of pressure in your body. So this is, say, the pressure generated by the left ventricle. As you move along through the various tubes within the body, the blood vessels, there should be a decrease in pressure. And the reason for this is with any moving fluid, as it moves through a stationary tube, there's interaction between the moving fluid and the walls. And so this leads to friction. And so some of the pressure is dissipated as heat. Now, there can be changes in diameter of the tube that would also lead to changes. So for example, if you have a constriction, which is shown here, then there's going to be more interaction between the moving fluid and the walls of the blood vessel, and therefore more dissipation of pressure as heat, and therefore you'd expect an even greater drop in pressure immediately after such a constriction, and that's what they're showing here. And at the same time, actually, this may create a kind of a back pressure. So you're preventing, you're adding a segment here where that it's thinner in diameter, and therefore there's more resistance to flow, and that may actually increase the pressure proximal to the source of the pressure, the pressure source, which is the heart. And so that's what's being shown here. So in this case, we're going to, by having a constriction here, we're increasing the pressure. So applying to the heart and the cardiovascular system, this constriction represents the arterioles, which are, of course, the small arteries right after the muscular arteries. And so when they constrict, they cause a lot of resistance, and so they're going to have a large impact on total peripheral resistance. And so in this case, when you have a constriction, you have an increase in total peripheral resistance, and therefore an increase in mean arterial pressure. And downstream of these constricted arteries, you would have a decreased pressure. As blood moves through the cardiovascular system, the blood pressure drops due to friction between the blood vessels and the walls of the blood vessels. And as you get to smaller and smaller blood vessels, which you can see here in this diagram, as we go from, say, the aorta to major arteries, which are elastic arteries, to muscular arteries, finally to arterioles, and then capillaries, there's a progressive decrease in the diameter of the blood vessels, and therefore there's more and more interaction between the moving fluid within the blood vessels and the walls of the blood vessels. And you can see here that as that occurs, there's a pressure drop, and the pressure drop is most notable when you get to the smaller arteries, and then the arterioles, and then the capillaries, of course, are very small in diameter, and so there's a very dramatic drop there. And then it continues to drop a bit as you go through the venous system, and then by the time the blood returns to the right atrium, the pressure is about 0 millimeters of mercury. It might be slightly higher than that. Another thing to note in this diagram, which is quite interesting, is if you look at the cross-sectional area. So the cross-sectional area of the aorta is quite small. Now, if you add up, this is the cumulative cross-sectional area. So we're adding up the cross-sectional area of all the arteries at any blood vessels at any particular stage. So, for example, next we have the major arteries. So the cross-sectional area goes up. By the time you get to the arterioles, the cross-sectional area is bigger. And by the time you get to the capillaries, the cross-sectional area, total cross-sectional area is at this highest point. And the reason for this is the diameter of the individual capillaries is very small, but there's so many capillaries that the total cross-sectional area is higher. And then the situation reverses as you go to venules, and then small veins, and then large veins. And finally, as you get to the inferior and superior vena cava, the cross-sectional cumulative cross-sectional area of those two veins is relatively small. So what's not shown in this diagram, but also we should note, is that as this cross-sectional area changes, there's also a change in velocity. So the velocity is initially quite high within the aorta, and then it starts to drop, and the velocity within the blood vessel is actually the lowest within the capillaries. And the reason for this is because of this large cross-sectional area. And then by the time we get back to the major veins, then the cross-sectional area is cumulative cross-sectional area is smaller, and the velocity increases again. As I mentioned earlier, the blood pressure is incredibly important. The mean arterial pressure is a regulated variable. It's sensed by baroreceptors in the carotid arteries as well as the aortic arch, and it's something that your body keeps within a very narrow range around a set point. which is roughly about 100 millimeters of mercury. Now, because it's so important, we have multiple mechanisms that are used to regulate blood pressure. Long-term mechanisms include the kidneys. The kidneys can control blood volume by regulating the amount of urine that's produced. So, for example, if the blood volume is too high, then we can have a response in which you will have a higher rate of urine production. In other words, you may have a higher volume of urine, and this reduces blood volume. So kidneys are definitely involved in blood volume regulation, and blood volume regulation has an effect on blood pressure. And the reason is that an increase in blood volume results in an increase in venous return. This will cause an increase in the end diastolic volume. An increase in end diastolic volume results in an increase in stroke volume due to the Frank-Starling law. Now, in the short term, we have other systems that can act to help maintain blood pressure. So the sympathoadrenal system stimulates vasoconstriction in arterioles. This raises the total peripheral resistance. From the equation we looked at earlier, this would lead to an increase in mean arterial pressure. The sympathoadrenal system can also increase cardiac output. That would also increase the mean arterial pressure. Oh, and I should mention that this sympathetic nervous system can also affect blood volume indirectly. An increase in sympathetic activity leads to vasoconstriction of the arterioles in the kidney, leading to a reduction in urine output. And so that would lead to maintaining blood volume high, and that would lead to an increase in blood pressure. The most important reflex for maintaining your blood pressure in the short term is the baroreceptor reflex. This reflex is activated by changes in blood pressure detected by baroreceptors, which are stretch receptors, which are located in the aortic arch here, and as well as in the carotid sinuses. Increased blood pressure stretches these receptors, increasing action potentials to the vasomotor and cardiac control centers in the medulla. So we can see here these are sensory fibers going into the medulla oblongata, which is the lower part of the brainstem. And these sensory fibers are traveling through the vagus and the glossopharyngeal nerves. Within the medulla oblongata, the vasomotor center controls vasodilation and constriction. This is primarily done through the sympathetic nervous system. Also within the medulla oblongata, we have the cardiac center, which controls heart rate, and it controls the heart rate with both effects on the sympathetic as well as the parasympathetic nervous system. So, for example, an increase in sympathetic nervous output coming through a spinal nerve, we have sympathetic nerve fibers that go to the SA node, sinoatrial node, where they release norepinephrine, and this causes an increase in the heart rate. Simultaneously, the parasympathetic nervous system has fibers that leave the brainstem through the vagus nerve. They make synapses also at the SA node. They release acetylcholine, which acts on muscarinic receptors there, and this has an inhibitory effect on the heart rate, so it slows the heart rate. If we look at an individual receptor and its response either to pressure, this could be a receptor either in the carotid sinus or in the aortic arch, you'll see as with an increase in mean arterial pressure, there's an increase in the frequency of action potential. So, for example, we could take our default state to be 100 millimeters of mercury. That's a typical mean arterial pressure. Let's imagine that the mean arterial pressure increases to 180 millimeters of mercury. You can see that the stretch receptor is much more active. It has a much higher frequency of action potentials. Let's go through the steps that are involved in the baroreceptor reflex when there's a fall in blood pressure. After all, a fall in blood pressure is probably, at least in the short term, more critical than an increase in blood pressure. The reason being that if you have a fall in blood pressure, you may not have enough pressure for adequate perfusion of the brain, and you may faint and so forth. So the body is very sensitive to fall in blood pressure. A fall in blood pressure leads to an increased sympathetic and decreased parasympathetic activity, and this results in increased heart rate and total peripheral resistance. Let's look at how this would happen. Well, you have a fall in blood pressure. So if you look at the baroreceptors in the carotid sinus and the aortic arch, they would have a decrease in spike frequency. This information would go in through the glossopharyngeal nerve as well as the vagus nerve to the medulla oblongata. And there, this information would be integrated, and it would lead to various effects on the changes in the sympathetic and parasympathetic nervous system. So there would be an increase in sympathetic nervous activity and a decrease in parasympathetic nervous activity. So the increase in parasympathetic activity, as I said in the previous slide, would lead to vasoconstriction at many of the arterioles throughout the body. And this would help to increase the total peripheral resistance, and this would help to increase mean arterial pressure, because mean arterial pressure, recall, is equal to cardiac output multiplied by total peripheral resistance. Now, at the same time, this increase in sympathetic nervous activity would lead to an increase in heart rate. Simultaneously, there's a decrease in parasympathetic nervous activity. Now, normally the parasympathetic nervous system slows down the heart rate. So if it's less active, it's essentially like taking the brakes off. So it's allowing the heart rate to increase. So an increase in heart rate will lead to a larger cardiac output, because cardiac output is the product of heart rate and stroke volume. Now you notice here that the sympathetic nerves also have synapses on the cardiomyocytes. Well, actually, this is showing here the AV node. So it actually does affect the AV node. It reduces the conduction velocity at the AV node. But there are also fibers going to the myocardium itself, to the cardiomyocytes within the ventricles, and it's not shown here. There's actually some fibers going to the cardiomyocytes within the atria. And what that does is norepinephrine release at those synapses leads to an increased contractility. And so that will actually aid in increasing the stroke volume. And so again, cardiac output is heart rate multiplied by stroke volume. So we're increasing the heart rate in this case, and we're also increasing stroke volume, or at least maintaining it. We've talked about why with increased heart rate, you have less time for filling the ventricles, so that could actually lead to a decrease in stroke volume. But this increased contractility would help to make up for that. So again, all these effects in total would lead to an increase in cardiac output. So now we have a combination of effects. We have mean arterial pressure being maintained by an increase in cardiac output, and also a increase in the total peripheral resistance. Let's imagine that something happens. Let's say you were to have an increase, a very acute increase in blood pressure. Well, then basically everything that I've talked about would be reversed. You'd have more parasympathetic output and less sympathetic output. So this baroreceptor reflex, again, is the most important reflex for short-term regulation of blood pressure. Let's look at the baroreceptor reflex in the context of what's called the orthostatic reflex or postural reflex. So this is when you go from lying down to a standing position. When you do this, there's a decrease in venous return, and the reason for this is if you stand up very suddenly, there will be pooling of blood in the lower extremities, and if you're not walking or running, then the venous return may be quite poor. So if you go from lying to standing, suddenly there's poor venous return. This leads to a lower end diastolic volume. A lower end diastolic volume then leads to a lower stroke volume, which leads to a lower cardiac output, which leads to lower mean arterial pressure. Now, what happens to the baroreceptors? What's the effect of going from lying to standing up on the action potential frequency of the baroreceptors? I'll let you think about that for a second. Okay, so then the baroreceptors send their information to the medulla oblongata, which is the lower part of the brainstem. And there you have the vasomotor center as well as the cardiac control center. And these centers have effects on the sympathetic and parasympathetic nervous output. to various parts of the body. So, for example, the sympathetic nervous system principally is responsible for vasoconstriction for the majority of arterioles in our body. And so you can imagine what we should have in terms of response should be vasoconstriction. This will lead to an increase in total peripheral resistance. This will then help lead to an increase in mean arterial pressure. At the same time, both the sympathetic and parasympathetic nervous system have an effect on cardiac rate. So in this case, this person, when they go from lying down to standing up, they should have an increase in cardiac rate to help make up for this poor venous return. And this will lead to an increase in cardiac output again, and this will also lead to an increase in mean arterial pressure. And so remember that what triggered this reflex was a decrease in blood pressure. Now we're increasing the mean arterial pressure, and therefore we have a negative feedback loop. We're bringing the mean arterial pressure back to its set point, which is roughly on the order of about 100 millimeters of mercury. So the answer to the question I posed earlier is there will be a decrease in action potential frequency. Recall that the higher the mean arterial pressure, the higher the action potential frequency within the baroreceptors. So we've talked a little bit about this baroreceptor reflex that occurs when you stand up. So this is referred to as orthostatic or postural hypotension, when you have a lowering of blood pressure upon standing up. And this may cause dizziness or fainting. Some common causes are dehydration. This would lead to a lower blood volume and therefore poor venous return. And so this is made even worse if you go from sitting or lying down to suddenly standing up. Certain heart medications may also affect contractility of the heart or heart rate, and therefore that could also lead to orthostatic hypotension. And interestingly enough, in elderly people after eating a meal, they may have, which is a postprandial state, they may also have orthostatic hypotension. And that may be due to an increase in parasympathetic nervous activity, which is what you'd expect after eating a meal because you would be in the process of digesting food. So we've talked about the baroreceptors in the carotid sinuses as well as in the aortic arch. As their name implies, they're stimulated by pressure. There's another type of reflex, which is the atrial stretch reflexes. And these are actually not activated by pressure, but by volume of the atria. And so they're also very important for regulating blood pressure. So within the atria, there are stretch receptors. And these are activated by venous return to the heart. What happens is there's increase in volume of the atria, and this stretches the walls of the atria. So it's really a volume effect rather than a pressure effect. And this, of course, this increase in volume stretches the atrial walls, leading to activation of these atrial stretch receptors. And they have three effects. The first one is they cause an increase in sympathetic activity that causes an increase in heart rate, which is called tachycardia. And this is necessary because it prevents pooling of the blood in the atria. So in other words, you have a lot of blood going into the atria. And so if you increase the heart rate, that helps the atria from ever overfilling with blood. So it's, in other words, you're receiving blood and you want to pass it on quickly into the rest of the circulatory system. So that's a very important effect that happens. Secondly, they cause a decrease in antidiuretic hormone release. Recall that antidiuretic hormone acting at the kidneys leads to increased water reabsorption from the filtrate that would normally end up turning into urine. So it essentially helps reabsorb the water back into the body and then helps to maintain blood volume. If you inhibit ADH, then you allow more water to pass through the tubules within the kidneys, and more water ends up in the urine. So you have essentially more volume of urine, and the urine is more dilute. And so this would help to decrease blood pressure because now you're reducing blood volume. The third effect is to stimulate the secretion of atrial natriuretic peptide, or ANP. This peptide results within the kidney in the excretion of more salts, NaCl, and as those salts are being secreted into the kidney tubules, where they'll eventually end up in the urine and be excreted, water will follow by osmosis. So in other words, the water follows the salts, and you end up with more volume of urine, and again, that reduces the blood volume because you're removing water from the system. Let's now look at how blood pressure is measured. Blood pressure is measured in millimeters of mercury by an instrument called the sphygmomanometer. The original measurements of blood pressure were done by Stephen Hales in a horse, and what he did was he essentially put a tube into an artery in a horse, and he was able to watch, and he'd see that essentially the blood pressure would oscillate between two values, the systolic and diastolic pressure. And he actually put off doing this. He had done similar measurements in other things like plants and so forth, and he knew that this was a measurement that needed to be done. But he actually put it off for a long time because he said the disagreeableness of the work did long discourage me from engaging in it. But he did eventually do it, and he was credited as the first person to sort of measure in a modern scientific way systolic and diastolic pressure. Now, luckily, because that's kind of an awful method of measuring blood pressure, this direct method, an indirect method was later discovered, which is also called the auscultatory method. And this was first described by Nikolai Korotkov in 1905, and that's the modern method that you can see here in this picture.
To understand how we use the auscultatory method to measure blood pressure, we need to understand that there are two types of flow. One is laminar flow. Laminar flow is when you have essentially a smooth flow within the tube. Now, the velocity is different. So towards the center of the tube, the fluid will have the highest velocity, and the velocity will decrease as the fluid, as you go in layers out to the very edge of the tube. But the main point is that the fluid flow is very smooth, and therefore there's no vibrations caused by the fluid moving through the tube. The other kind of flow of a fluid through a tube is turbulent, and that occurs when you have changes in diameter of the tube. So you might go from large to small to large. And as you go particularly from the small to the large, you'll have turbulent flow of the fluid. And this causes vibrations because the fluid is now essentially pushing against the sides of the tube, and it causes vibrations. And this is exactly what causes the Korotkov sounds, which you can measure and listen to using a stethoscope in the human body. So let's look at this example here. So we have a blood pressure cuff, which is placed on the arm, on the brachial, covering the brachial artery. Now, if we increase the pressure within the cuff such that it's higher than the systolic blood pressure, then the brachial artery will be collapsed or closed, and therefore, when we listen, there'll be no sound. Now, as we gradually let the pressure decrease, eventually the pressure will become lower than that of the systolic blood pressure, and that means blood will be able to get through during systole. And so you'll have spurts of blood with each heartbeat, and you'll have turbulent flow because you'll be moving from a region of small diameter to larger diameter. And this you can hear quite easily with the stethoscope, and that will be the first Korotkov sounds, and that gives us an indication of the systolic blood pressure. As we continue to let the pressure decrease on the cuff, the sounds will continue with each systole. Remember that during diastole, the diastolic pressure is lower than systolic blood pressure. And if the cuff pressure is greater than the diastolic pressure, then the brachial artery will be occluded or blocked or collapsed, and there will be no blood flow during diastole. Now, eventually we get to the point where the cuff pressure is about equal to that of the pressure at diastole. This means that the cuff will no longer constrict the blood vessel and will switch from turbulent flow to laminar flow. And remember that laminar flow is silent. It doesn't create any vibrations within the tube or the blood vessel. And so the point at which we hear the last carot cuff sound essentially tells us what the diastolic blood pressure is. This diagram shows very nicely the different types of flow as well as the first and last carot cuff sounds. So on the x-axis, we have time. And so what's happened is we've increased the cuff pressure to above the systolic pressure. Let's say it's 140 millimeters of mercury. Notice that the blood pressure is oscillating between systolic and diastolic pressure. It's going up and down. Now, initially, the cuff pressure is higher than the systolic blood pressure, and so there's no flow, and that's because we've blocked the brachial artery due to the cuff pressure being higher than that of the systolic pressure. When we reach systole, then we have spurts of blood coming through, and because of the change in diameter of the tube, the blood vessel, we have turbulent flow, and so we'll hear the first carot cuff sound. And we'll continue to hear carot cuff sounds with each systolic pressure wave. And then eventually we get to the point where we reach the diastolic blood pressure. And so we would have heard our last sound just prior to that, when there was still some constriction of the brachial artery and therefore still some turbulent flow. So we would have had our last carot cuff sound. And once we actually reach the diastolic pressure, there is no further carot cuff sounds. The artery becomes silent. And we would take this measurement where we hear our last carot cuff sound to be the diastolic pressure. So in this case, it's 80 millimeters of mercury. And this diagram also indicates that here we've gone from turbulent flow to now laminar flow, which is silent. This diagram shows in detail the different types of sounds. So initially, when there's no blood flow, we have silence. The initial sounds are sometimes described as snapping sounds. Notice that the relative intensity of the sound increases during this early phase. After that, we have murmurs. So these are less sharp sounds. Then we have thumping and muffling just before the proceeding to silence. So we would have measured systolic blood pressure here with the first snapping sound, and then diastolic with the last muffling sound. Now the book points out, and I think it's important, that in some people the carot cuff sounds do not disappear even when the cuff pressure is reduced to 0, which means that it's the same as atmospheric pressure. So in this case, the onset of the muffling sounds can be used to indicate the diastolic pressure. So another thing that's measured routinely is the resting heart rate. And so this is referred to as taking the pulse when you measure this heart rate. And the way this is done, you could do it in the wrist. You would place 2 fingers between the bone and tendon over the radial artery. So this is the artery that's closer to the thumb. And you can, if you do that, you can feel right away the pulse pressure there. So what this is an increase in blood pressure in the artery at systole. And so the pulse pressure is defined as the difference between the pressure at systole and diastole. So an example would be with a person with systolic pressure of 120 millimeters of mercury and a diastolic pressure of 80 millimeters of mercury. The pulse pressure would be simply the difference, or 40 millimeters of mercury. And so this pulse pressure is a reflection of stroke volume. So let's imagine, for example, the person is exercising. Then the systolic pressure might increase a lot more. Could go up to even, say, as high as 200 if it was really intense exercise. And in the case of exercise, the diastolic pressure doesn't increase as much. And so if you then, it'd be very easy to measure the pulse, because you should feel a very strong pulse pressure. And that's a reflection of the fact that there's a big difference in pressure there.
The mean arterial pressure is a very important parameter that tells us about the health of a person. It's significant because it's the difference, it's the pressure that drives blood flow through the various organs of the body. So, for example, if mean arterial pressure drops too low, there won't be enough blood flow through the brain, and therefore a person might faint or feel dizzy. Now, we typically will measure two pressures, though, systolic pressure and diastolic pressure. And this can be converted to a mean pressure for a person at rest by doing this formula. So we have diastolic pressure. So, for example, in this case, a person has a diastolic pressure of 90, and they have a systolic pressure of what looks like about 135. So you take the diastolic pressure, and then you add 1/3 of the pulse pressure. And the pulse pressure is simply determined by taking the systolic pressure minus the diastolic pressure. And this would then give us an estimate of the mean arterial pressure. Of course, if you have data, which is being done here, they're collecting data with a computer, then you could just simply take the true mean arterial pressure, which would be the timed average of all these data points. So this rule works when a person's at rest. If a person's exercising, it doesn't work because there's less time spent in diastole. So it'd be a little bit harder to use this formula. In fact, it wouldn't be accurate for a person who's exercising, but it works very well for a person who's at rest. We're next going to apply some of the things we learned about normal cardiac function to various disease states, including hypertension, shock, and congestive heart failure. Hypertension is high blood pressure. It's defined as having systolic pressure of 140 millimeters or greater, or a diastolic pressure of 90 millimeters or greater. The incidence of hypertension increases with age. It can increase the risk of cardiac diseases, kidney diseases, and stroke. Hypertension can be divided into either essential or secondary. Essential or primary hypertension is the result of a complex of poorly understood processes. This is the most common form of hypertension. And basically, this means that there's no single identifiable cause. It's probably a complex of different things that occur with advancing age, as well as perhaps being out of shape or overweight, those sorts of things. Secondary hypertension is a symptom of another disease. So, for example, a person might have a kidney disease, which would cause hypertension. So, for example, a decrease in urine formation would lead to an increase in blood volume, and that might cause the hypertension. With secondary hypertension, if you can solve the primary disease that's causing the disruption in, say, blood volume, then that would lead to solving the hypertension problem. This table indicates various blood pressure classifications based on systolic blood pressure and diastolic blood pressure, as well as different therapies. As I stated previously, with secondary hypertension, there is an identifiable cause for the hypertension. So, for example, with kidney disease, there might be decreased urine formation, which would mean that there's more water retained within the blood plasma, and this would lead to an increase in blood pressure. Another possibility is the kidney secretes certain vasoactive chemicals. So, for example, the kidney may secrete renin, which activates the renin-angiotensin-aldosterone system, or RAS. This system leads to an increase in blood pressure through vasoconstriction, as well as through the retention of sodium chloride and water. So those changes would lead to an increase in blood pressure. Another possibility is you might have, for example, an endocrine problems. So, for example, excess catecholamines, which would be epinephrine and norepinephrine. If they're released, they can lead to an increase in cardiac output, and they can also lead to vasoconstriction. And this would increase the total peripheral resistance. So both of those changes would lead to an increase in the mean arterial pressure. Another possibility is there might be excess secretion of aldosterone. Aldosterone is a hormone that leads to retention of sodium and chloride within the kidneys, and as a consequence of that, there's osmotic movement of water, so water also ends up being retained. within the body, and that would lead to an increase in blood volume and therefore an increase in blood pressure. Essential hypertension is the most common form of hypertension. So most people fall into this category. It's the type of hypertension where it's difficult to determine exactly the cause, and the actual cause may be quite complex with various interacting factors. So for example, here's a few possibilities. One is you may have an increased dietary salt intake, which can lead to higher blood pressure. The salt intake would lead to an increase in plasma osmolality, which would stimulate the release of antidiuretic hormone. Antidiuretic hormone causes water reabsorption in the kidney, which increases blood volume. And this increase in blood volume would lead to an increase in cardiac output and therefore the increase in blood pressure. Normally, when people are young, increased dietary salt is usually not as big of an issue. But as people start to get older, their ability of the kidneys to secrete this excess salt declines. And therefore, we have more difficulty as a person ages with dietary salt. Another possibility is you may have increased sympathetic nervous activity. Now, normally, when a person has high blood pressure, there would be activation of the baroreceptor reflex, which would lead to a decrease in sympathetic nervous activity. However, when there are certain chronic conditions in which the baroreceptor reflex seems to not really be active, and so there may even be increased sympathetic nervous activity. And this leads to an increased heart rate, and also it leads to the promotion of vasoconstriction, both of which lead to high blood pressure. Yet another possibility is you may have abnormal release of paracrine regulators from the endothelium. So, for example, you may have increased release of endothelin. This is a paracrine signaling molecule that leads to vasoconstriction. You may also have decreased secretion of nitric oxide, NO, and normally nitric oxide leads to vasodilation. So if you have less nitric oxide, then there would be less vasodilation. So both of those changes would lead to an increase in blood pressure. Finally, you might have increased total peripheral resistance, and this could happen due to the narrowing of lumina of arteries. High blood pressure can cause vascular damage, and people are often asymptomatic until substantial vascular damage has occurred. For this reason, hypertension is often referred to as a silent killer. Vascular damage can occur within organs, especially within the brain. The cerebral vessels are very delicate, and so this could potentially lead to stroke. Hypertension increases the afterload that the heart has to work against. So in other words, when the ventricles eject blood, the pressure within the blood vessels constitutes an afterload. And so the higher that pressure it is, the more difficult it is for the ventricles to eject blood. And this can lead to hypertrophy of the ventricular walls, meaning the ventricular walls get thicker. Now, initially, that's a good thing because it means the heart gets stronger. But over time, the heart wall can actually weaken, even though it's thicker. This can also lead to arrhythmias and cardiac arrest. Finally, hypertension can also lead to the development of atherosclerosis. There are quite a few different treatments for hypertension. The first treatment is simply a lifestyle modification, and this may actually be one of the most effective types of treatments. Limiting salt intake, specifically sodium chloride intake, can be very helpful. Limiting smoking or cessation of smoking is helpful. Limiting or ceasing to drink alcohol is helpful. Losing weight is very helpful, and exercising daily is very helpful. Now, it turns out it's very interesting, but sodium chloride tends to be bad. This is table salt. But potassium is actually good. So potassium is found naturally in foods such as bananas. And so it's been found that actually a diet rich in potassium can actually lead to lower blood pressure. And it also appears that calcium may have a similar effect. And calcium you have to be a little bit pay a little bit of attention to, because you don't really want to take too much calcium. But certainly calcium supplements to a small degree can be helpful, as well as foods that have calcium. Diuretics are also very helpful. Diuretics are, to remind you, these are drugs that lead to increased urine formation. And so if you increase urine formation, this leads to a reduction in blood volume. This leads to less venous return, lower end diastolic volume, and therefore smaller stroke volume, and therefore lower cardiac output. Another very effective class of drugs are beta blockers. These can decrease cardiac rate. So beta blockers are antagonists of beta adrenergic receptors. Those are found in various places, including the SA node in the right atrium, which is the pacemaker. So beta blockers would reduce heart rate. And they would also reduce the ability. One problem with beta blockers is they really reduce the ability of a person to exercise. So that is one downside to beta blockers. When you exercise, you should have an appropriate increase in heart rate as you're exercising. And that's actually blocked by beta blockers. So that is a big disadvantage of that drug. Another type of drug that's quite often used are ACE inhibitors. And these block angiotensin II production. So that ACE is angiotensin converting enzyme. It converts the hormone angiotensin 1, which is relatively inactive, to angiotensin 2, which is very active. Angiotensin 2 is a potent vasoconstrictor. Angiotensin 2 also stimulates aldosterone secretion. Aldosterone is a hormone that causes salt retention within the kidney, and as a consequence of the salt retention, we have osmotic flow of water, and you get water retention also. So if you inhibit those processes tend to increase blood pressure. So if you inhibit them, you get a decrease in blood pressure. Finally, another class of drugs, and there are many different ones in this class, are angiotensin II receptor blockers. So these blockers bind to the normal receptors for angiotensin II, and they would prevent the vasoconstrictive effect of angiotensin II, and they would also prevent the ability of angiotensin II to stimulate aldosterone secretion. This table describes various categories of drugs that have antihypertensive effects. We're next going to explore the topic of circulatory shock. Circulatory shock occurs when there's an inadequate blood flow to match oxygen usage in tissues. So some of the symptoms result from inadequate blood flow and how our circulatory system has changes that compensate for this inadequate blood flow. And it's quite serious. So sometimes shock actually leads to death. So here are some signs of shock. You can, for example, have decreased blood pressure or pulse pressure. Later on, you might see decreased systolic pressure. Increased diastolic pressure is another sign, and so forth. So these are things you would look for to indicate that someone actually has shock. So with shock, there is inadequate perfusion of organs. So in order to compensate for this, there are a number of different compensatory mechanisms. The heart will beat faster, and there'll be an increased stroke volume, and this is due to sympathoadrenal stimulation. And the reason for this increased stroke volume is due to increased myocardial contractility. At the same time, when you're in a state of shock, the body prioritizes certain organs. The two primary organs that are prioritized are the heart and the brain, and I think also some of the respiratory muscles also. But so in a sense, those are prioritized, and other organs are less prioritized. So, for example, there'll be a decreased blood flow during shock via vasoconstriction. And this vasoconstriction is a result of sympathetic nerve stimulation. So norepinephrine is being released at synapses onto alpha adrenergic receptors. And this decreased blood flow would occur in these less vital organs, such as the digestive tract and skin. And so you would expect, for example, someone with in shock would have very pale skin because they'd have less blood flow to the skin. Kidney will have a decreased urine production as a result of sympathetic nerve-induced constriction of renal arterioles. So again, we have a lot of sympathetic nervous activity, and this leads to a reduction in essentially the blood flow to the kidney, and therefore less urine production will occur. And there'll also be other changes, such as there'll be increased salt and water retention due to increased plasma levels of aldosterone. And antidiuretic hormone leads to water retention in the kidney. So far, I've been speaking about circulatory shock in general, but there are various different types of circulatory shock. One is hypovolemic shock. This is shock due to low blood volume from an injury, such as hemorrhage. You could have dehydration leading to low blood volume or burns. So there's a hypovolemic shock is characterized by low blood pressure and decreased cardiac output. And so in this situation, blood is diverted to the heart and brain at the expense of other organs. And of course, if you have a decrease in blood mean arterial pressure, then you should have activation of the baroreceptor reflex. And that's exactly what happens. This reflex becomes activated, and this leads to activation of the sympathetic nervous system, as well as a lowering of the activity level of the parasympathetic nervous system. So what happens with this is with the sympathetic activation, you get increased heart rate as well as increased heart contractility. The sympathetic nervous system releases norepinephrine at the smooth muscle and many of the arterioles in the body, which have alpha adrenergic receptors. This leads to vasoconstriction, and this raises the total peripheral resistance. That's helpful in increasing mean arterial pressure. Recall that mean arterial pressure is cardiac output multiplied by total peripheral resistance. So this reflex leads to an increase in cardiac output and also an increase in total peripheral resistance. Because of the redirection of blood towards the heart and brain, people that have this hypovolemic shock will typically have cold, clammy skin. That's because they have less circulation going to the skin and also to the GI tract. And there's also going to be less blood flow to the kidney, and therefore there'll be a lower urine output. Septic shock is another very dangerous type of circulatory shock. It leads to dangerously low blood pressure or hypotension, and it's due to an infection or sepsis. Bacterial toxins called endotoxins induce nitric oxide production, which causes widespread vasodilation. This reduces the total peripheral resistance. Recall that mean arterial pressure is cardiac output multiplied by total peripheral resistance. So if the total peripheral resistance decreases and cardiac output doesn't increase sufficiently, this will lead to a decrease in mean arterial pressure. And of course, a decrease in mean arterial pressure may lead to insufficient perfusion of the various organs in the body. And so this is a very serious condition. The mortality rate is very high, 50 to 70%. So interestingly, septic shock may be treated with drugs that inhibit the production of nitric oxide. So there are, in fact, treatments for this very deadly disease. So briefly, there are other types of circulatory shock. There's severe allergic reactions that can cause anaphylactic shock. And this is due to the production of histamine. Histamine normally acts locally, but in certain situations, you may have histamine released in such a large quantity that it now acts throughout the body and it could cause vasodilation throughout the body, and this could lead to a reduction in mean arterial pressure, which could be it could be deadly. Additionally, you have spinal cord injury or anesthesia, which can cause neurogenic shock, which is due to the loss of sympathetic activity. Recall that normally you have sympathetic activity and it's balanced with parasympathetic activity. But if you suddenly have a loss of sympathetic activity, this could lead to the parasympathetic nervous activity being dominant, and this will slow down heart rate and essentially reduce cardiac output. And it will sympathetic nervous system's also involved in a sort of tonus or tone to the smooth muscle of arterioles throughout the body. So if that goes away, then the arterioles will vasodilate, and this would also have the effect of reducing the total peripheral resistance. So for both those reasons, a decrease in cardiac output as well as a decrease in total peripheral resistance, both of those changes would lead to a decrease in mean arterial pressure. Finally, cardiac failure can also lead to circulatory shock, and that's called cardiogenic shock. And this is due to a myocardial infarction, also known as a heart attack. So in a myocardial infarction, there's been hypoxia to a portion of the heart. So there's not enough oxygen to this heart, and you start the process of necrosis where the tissue actually starts to die. And this can lead to essentially insufficient pumping of blood by the heart, and that leads to this low blood pressure situation of cardiogenic shock. We're going to end by looking at congestive heart failure. This occurs when cardiac output is not sufficient to maintain blood flow required by the body. It's caused by myocardial infarction or heart attack, which can weaken the heart muscle. It could also be caused by congenital defects of the heart. It can be caused by hypertension. Hypertension increases the afterload on the heart, which can lead to hypertrophy of the ventricles, which can lead to weakening of the contraction force. It can also arise from aortic valve stenosis. Stenosis has to do with a narrowing of the valve, and that would mean that less blood could be ejected during the ejection phase of ventricular systole. It could also be caused by valve incompetence. Valve incompetence means the valves don't close properly. That could again lead to less efficient pumping by the heart. And finally, it could also be due to disturbances in electrolyte levels of potassium and calcium. These can lead to abnormal rhythms as well as abnormal ability to contract in the heart. The name congestive heart failure refers to the fact that there can be a congestion, meaning there's excess blood flowing back to the heart that's not very effectively pumped back out immediately. Normally, when blood comes back to the heart, it needs to be pumped immediately out again. So let's take left side failure. Let's imagine that the left ventricle is pumping, but not with enough force. Well, this means that, recall that blood is coming back from the pulmonary circuit to the left side of the heart. And so if the left ventricle isn't able to eject the blood with enough force, then you can actually have this excess venous return occurring at the site of the left atrium. And so what happens with this type of congestive heart failure is there'll be a raised left atrial pressure. And this pressure normally shouldn't be very high at all, and so if it's high, it's going to produce pulmonary congestion, meaning that the blood is sort of backed up into the pulmonary circuit a bit. This causes an increase in the blood pressure within the pulmonary capillaries, and this leads to edema because there's hydrostatic pressure that leads to the movement of water out of those pulmonary capillaries. And there's not really much space for this water to go into. It'll go into interstitial space within the lungs, but it will also end up in the alveoli themselves. Remember those, the little air-filled sacs. And normally those are moist, but they shouldn't really have a lot of water in them. And what can happen is those little alveolar sacs will actually start to fill up with water if the pulmonary edema is quite extensive. And this will then lead to shortness of breath because it causes problems with diffusion of oxygen in from the alveolar airspace into the pulmonary capillaries. So this could be deadly. So it can be treated with drugs, but it's quite a very serious problem. It's pulmonary edema that arises from left side failure. Now, the other possibility is you can have a right side failure. Now, this, for very similar reasons, is going to raise the right atrial pressure. And the reason is that the right ventricle is not able to pump the blood very efficiently or effectively into the pulmonary trunk and therefore into the pulmonary arteries, into the pulmonary circuit. And then, but at the same time, blood is coming back from the heart, from the rest of the body through the systemic circuit. And so you get this congestion, you have excess volume and pressure within the right atrium. And so again, this can back up into the systemic circuit, and you can have systemic congestion and edema. So of these two, the left side failure is probably more common because the left side of the heart has a harder job to do. It has to pump to the whole systemic circuit, but it is possible. You can have right side failure also.